let's say we've got a patient on a JAK inhibitor, what are some of the emerging therapies that you could add on to the JAK inhibitor, for example, to alleviate anemia?
Yeah, so the first thing I would say is older therapies. We talked about ESA a little bit already, danazol. I mean, the data for ESA and danazol is pretty weak in general. I mean, I think a lot of it's more feasibility, like you can do this. Right. And you can access these medications, and they're not extremely toxic. So, but I would say the efficacy data for those agents is pretty limited, and so we're certainly trying to do a little bit better than that. And I think luspatercept, while not approved for myelofibrosis right now, certainly has data in the phase 2 setting suggesting pretty robust responses in a subset of patients, especially those who are transfusion dependent on ruxolitinib, and certainly it's approved for kind of a broader indication of myelodysplastic syndrome right now. So I think that becomes an option as well. I think there's certainly exciting things coming down the pipeline to look at as well.
What do you think, Gabby?
Yeah, no, I agree. I mean, I think if I have a patient that is on a JAK inhibitor and they develop anemia, some patients it's really hard to get them off of their ruxolitinib, especially those patients that have really significant splenomegaly, significant symptoms. Those are still patients where I think it's still pretty reasonable to add other drugs to them, but like Andrew said, there is modest response, so it's good to know that we can at least sequence them. And I think generally speaking, we don't know what the optimal way of sequencing these patients.
I like using like two different examples. You have someone on Rux enjoying spleen and symptom benefit, but that hemoglobin is going down. They're maybe needing a transfusion every once in a while. That's one scenario. Maybe the other scenario is you have someone on Rux, spleen is still pretty big, they're still having some symptomatology, and their hemoglobin's going down. Gabby, I'll start with you. Where would you maybe add something to Rux, like luspatercept, versus switch to momelotinib or pacritinib?
So that first patient you described, I think that one sort of depends on what's going on, but I would be more inclined to add something to that patient because they are doing pretty well, especially if they're very symptomatic before. But certainly have a low threshold to switch them over to momelotinib if I don't see an improvement relatively quickly. The second patient you described is somebody that concerns me a little bit more, and where I feel like I definitely would not want to keep that person on ruxolitinib if I feel like I'm have dose-limiting anemia, that I can't improve the I can't improve the splenomegaly and symptoms anymore, and they're developing more anemia. So for that patient, I'd be willing to switch them over, but also being very aware of the fact that progressive splenomegaly on ruxolitinib is something to also be concerned about. Yep. And so if I have a clinical trial available to either add it on or do something, and a novel mechanism of action, I would do that. And otherwise, I think starting to think about transplant pretty seriously, if I hadn't been thinking about that before, would be really important at that time.